Okay, so now let's go to the NPNs, or the non-protein nitrogen compounds. So these are the substances that we test to determine the renal function of the patient. Okay, so what are the NPNs that we have to study? So there are four: urea, uric acid, creatinine, and ammonia. So let's go through that one by one. So first, let's start with urea. So urea is the NPN with the highest concentration in the blood. So it is the major NPN in the body. Okay, so urea is the major NPN in the body. And then it is the major excretory product of protein metabolism. So kapag the proteins in the body are metabolized, or parang broken down, it will become urea. Okay? It will become urea. And then BUN is actually blood urea nitrogen. So pag tingnan nyo yung mga parang at test results na may ibang test results na BUN ang nakalagay, so that is actually blood urea nitrogen. Pero obsolete na yan siya na term, kasi dapat we have to use urea. We don't just measure the nitrogen in urea. We have to measure urea as a whole. So kapag you will be given a measurement in BUN, so you have to multiply it by 2.14 for you to get the measurement of urea. Okay, so kunyari 10 mg per dl ang BUN. So 10 times 2.14, so 21.4 mg per dl of urea. And when you look at this figure, so ito ang ating urea. So there is oxygen, then carbon dioxide. Para siyang carbon dioxide kasi may carbon ito dito sa gitna, then O, and then 2 parang amino group. Okay, so 2 amino groups, and then 1 carboxyl group. Okay, 2 amino groups and 1 carboxyl group. So then how is urea produced? Okay, so actually urea is produced through the urea cycle. So urea is formed in the liver. Okay, sa liver siya na-form. Ito sa liver. From carbon dioxide, kasi 'di ba carbon dioxide, ito carbon dioxide, and ammonia. Ammonia is NH3, 'di ba? Or NH4+. So ito ammonia, then carbon dioxide. So ammonia is derived from the deamination of proteins. Kasi 'di ba protein metabolism, major excretory product of protein metabolism. So yung protein, endogenous and exogenous, kunyari yung kinakain mo na protein or yung protein from the body mismo, that will undergo proteolysis, so broken down into amino acids, and then amino acids are deaminated to form ammonia. Okay? So amino acids are deaminated to form ammonia, and that ammonia will be combined with carbon dioxide to form urea. Okay, it will form urea. So that urea cycle will be happening in the liver. Okay, so don't forget ha, sa liver siya nangyayari ang production of urea. And then urea are excreted in the kidneys. Okay, so 90% excreted in the kidneys dito, and it will appear in the urine. And less than 10% are excreted in the GI tract and the skin. So ito, GI tract and the skin. Okay? So don't forget, 90% is excreted in the kidneys. Kasi nga, di ba, kidney function test. So dapat mostly will be excreted in the kidneys. Okay? So concentration of urea in the blood is affected by. So what will affect the urea concentration? So first, protein content of the diet. Kasi nga, di ba, it is a product of protein metabolism or protein catabolism. Next, rate of protein catabolism. So kapag masyadong grabe ang breakdown ng proteins mo. So for example, grabing diet mo, hindi ka kumakain. So sabi ng body mo, I need energy. So ang gagamitin niya for energy ay ang proteins ng iyong muscles. So na breakdown ang muscles mo. So yun siya, you will have increased urea kasi there is protein metabolism from the muscles. So kapag marami ka namang kinakain na protein, so protein content of the diet, 'di ba? Kapag marami kang kinakain na protein, so grabe, whey protein ka or naga-workout ka, tapos grabing kain mo, naga-load ka. So, you will have increase in urea. Okay? So, tingnan nyo itong mga factors that will affect the concentration of urea. So, again, renal function and perfusion. Kasi, di ba, when there is failure of renal function, the urea will not be excreted in the urine and will accumulate in the blood, leading to increased urea in the blood. Okay? So, when I ask you mga certain scenarios, you go back to the principle. Okay? So, kanyari, i-ask ko kayo, hindi ka kumakain ng protein, naga-diet ka without protein or no protein diet. So, kapag no protein diet, increase or decrease in urea? Decrease. Kasi 'di ba, it is the product of protein metabolism. Okay? So, sa exam ha. Next, what are the disorders that can affect the concentration of urea? So actually, the elevation of urea in the blood is called azotemia. So when you see that word azotemia, that is the elevation of urea in the blood. Okay? And then uremia, 'di ba? You also see this word uremia. Uremia is actually azotemia accompanied by renal failure. So elevation of urea na may renal failure ang patient, that is called uremia. Okay, so azotemia, elevation of urea, uremia, azotemia, plus renal failure. So what are the causes of azotemia? Diba, azotemia is elevation of urea. So what can cause elevation of urea in the blood, guys, sa blood, hindi urine, in the blood? So what can cause increase of urea in the blood? So it can be pre-renal or before the kidney, renal, kidney, and then post-renal after the kidney. Okay? So, tingnan nyo dito. Ito yung kidney natin, diba? Then, there are causes of azotemia na pre-renal. So, ito pre-renal before, and then renal sa kidney mismo, then post-renal. So, what are examples of pre-renal azotemia? So, itong pre-renal azotemia, mostly ito siya because of decreased flow of the blood to the kidneys. Kasi 'di ba, when there is decreased flow of blood to the kidneys, wala masyadong blood na pumupunta sa kidney to be filtered. So that's why ang urea magstay siya sa blood kasi hindi nga siya ma-filter sa glomerulus kasi hindi siya pupunta or hindi siya mag-flow to the glomerulus. So how can it be filtered, 'di ba, kung hindi siya pumunta sa kidney? So pre-renal azotemia is actually the failure of the blood to be perfused to the liver to be filtered. Okay? Gets nyo, guys? So, pre-renal. So, for example, congestive heart failure. So, ang meaning ng congestive heart failure, so the heart cannot pump the blood to the kidneys. So, mag-congest lang siya sa heart, lang siya magstay. So, it cannot pump the blood to the kidneys. So, kapag no blood will be perfused to the kidneys, hindi din ma-filter ang blood. So, yung urea, magstay siya sa circulation. Okay? Ito, for example, shock, hemorrhage, loss of blood, 'di ba? Parang siya, mag-lower ang blood volume mo. So, kapag lower blood volume, lower perfusion to the kidneys, and there will be increased urea in the blood kasi magstay siya sa blood. Okay? So, dehydration, the same lang yan. Basta mga CHF, shock, hemorrhage, dehydration, those are pre-renal causes of azotemia. So, ito, increased protein catabolism, I already said that earlier. Diba kasi pre-renal siya kasi wala namang sila sa kidney mo. Before siya pumunta sa kidney, yun ang iyong pathophysiology. And then again, high protein diet. Okay? So, we're done with pre-renal. So, next, renal. So, acute and chronic renal failure. Kasi 'di ba, when you have renal failure, hindi ma-filter ng kidney ang ating urea. And when the kidneys cannot filter the urea, these will accumulate in the blood. Okay? So there will be increased urea in the blood. Okay, so mga renal disease, basta lahat ng renal disease and renal failure, those are renal causes of azotemia. So, para siyang uremia, causes of uremia. Kasi nga, may renal failure siya. Plus increase in urea. Okay? Next, post-renal, urinary tract obstruction. So, dito na siya sa after sa kidney. Doon siya sa mga ureter, urinary bladder. So, when there is obstruction in the ureter, kunyari, may obstruction sa ureter, may stone dyan sa ureter. So, kapag may stone dyan sa ureter, parang mag-backflow ang ating urine to the kidneys, 'di ba? Mag-backflow siya kasi hindi nga niya ma-excrete sa ureter. So kapag backflow ang urine dito sa kidneys, hindi na din maka-filter ang kidneys kasi wala siyang paglagyan ng kanyang mafi-filter. So mag-stop lang ang blood, mag-stop lang lahat dito before the obstruction. So 'di ba? Obstructed dito sa ureter. So ang urine mo kay mag-backflow siya papunta diyan. So mag-stagnant ang urine mo until the kidneys. So sabi ng kidneys, asan ko pa man ilagay ang aking ma-filter na urine? Wala na. So hindi na lang ako mag-filter kasi hindi ko naman siya kayang store. So kaya yun, hindi niya na ma-filter ang blood. So mag-stop na lahat ng mechanisms dito. Kaya there will be increased urea in the blood kasi hindi na niya ma-filter. Okay, that's why post-renal injuries can also cause azotemia. Okay? So for example, may tumor sa bladder or may tumor dito sa ureter, so that will obstruct the urinary tract. Okay? So ito, decreased concentration. So low protein intake, severe vomiting and diarrhea kasi 'di ba yung mga kinakain mo, sinusuka mo na, so wala kang nutrients and the body will use your muscles or other proteins sa iyong body to compensate for the loss in energy. So liver disease kasi 'di ba where is urea produced? It is produced in the liver. So when there is liver disease, the body cannot produce urea in the liver. And then pregnancy kasi kapag pregnant ka, there will be increased blood flow to your kidneys. So kapag increase ang blood flow mo to your kidneys, increase din ang filtration ng urea. Okay? So again, hindi nyo ito kailangan i-memorize. Kailangan nyo i-understand and take into heart so that you will know if there is pre-renal, renal, or post-renal azotemia or decreased urea in the blood. Okay? So how do we differentiate the different types of the causes of azotemia? So we will measure the urea creatinine ratio. So divide nyo ang urea sa creatinine. So normally urea is 10 to 20 times more than the creatinine. So 10:1 to 20:1. Okay? So when there is pre-renal azotemia, so memorize nyo lang to, high urea to creatinine ratio. Okay? When there is renal azotemia or uremia, normal urea creatinine ratio. And when there is post-renal azotemia, same sila ng pre-renal, high urea creatinine ratio, pero ito with high creatinine. Okay? So dito low ang creatinine dito sa pre-renal. Dito high ang creatinine, tapos high pa talaga ang ratio, so masyadong malaki ang urea. Okay? So again, memorize nyo lang yan. And then low urea creatinine ratio when there is low protein intake, severe liver disease, kasi 'di ba nga you don't have protein or you can't make urea kasi you don't have protein and you can't make urea in the liver. Okay? So gets nyo na yan, guys. Memorize nyo lang ang urea creatinine ratio ng different types of azotemia and kapag low ang urea creatinine ratio. Okay? So ito, this is a patient, kunyari a patient with azotemia. So kailangan natin i-remove ang urea sa blood niya through dialysis. Kasi 'di ba nga hindi kaya ng kanyang kidneys i-filter or i-excrete ang urea. Okay? So we're done with urea. Let's go to creatinine. So next, creatinine. So creatinine is formed from creatine and creatine phosphate in the muscle. Okay? It is formed from creatine and creatine phosphate in the muscle. So sa muscle siya na-form ang creatinine. 'Di ba ang ang urea, it will be formed in the liver, 'di ba? Pero ang creatinine, it is formed in the muscle from creatine and creatine phosphate. So uh, it will be easy to say na it is in proportion to the muscle mass. So kapag malaki ang iyong muscle mass, so kapag bodybuilders, there will be more creatine and creatine phosphate. That's why there will be more creatinine. Okay? So kapag malaki ang muscle mass, there is increased creatinine. So kapag wasted ang body, kunyari yung mga masyadong payat, yung mga hindi kumakain, there will be decreased creatinine kasi decreased muscle mass. So plasma creatinine is an indirect measure of glomerular filtration rate because its molecular weight is only 113 daltons. Kaya nga, 'di ba, 113 daltons, it is less than 60,000 daltons or 60 kilodaltons. So dapat na-filter ng ating glomerulus ang creatinine. So that's why it is an indirect measure of GFR. Kasi 'di ba pag increased ang ating plasma creatinine, there is renal failure kasi the glomerulus cannot filter the creatinine. Okay? So what about diet? Can it affect the creatinine? So it actually cannot or does not affect the creatinine levels. So dun lang siya sa muscle mass naga-depend. So, how is creatinine formed? So, 'di ba, creatinine is made from creatine and creatine phosphate. So, creatine is made from, so 'di ba ito, creatine, it is made from arginine, glycine, and methionine. So, arginine, glycine, ito, methionine. That will create creatine in the muscle. Then, it will become creatine phosphate, which is a high energy compound. So yun yung ginagamit ng ating muscles kasi it is a source of energy. Creatine, it will become creatine phosphate or phosphocreatine using creatine kinase as an enzyme. Okay, so creatine will become creatine phosphate or phosphocreatine with the help of creatine kinase. And then itong creatine and phosphocreatine, kapag magamit na sila ng muscle, na gamit na sila for energy, they will become creatinine. Okay? So, creatine will become creatinine when it loses water. Okay? Creatine minus water will become creatinine. Then, phosphocreatine minus phosphoric acid, it will become creatinine. Okay? So, remember nyo ha, creatine with minus water will become creatinine, then phosphocreatine minus phosphoric acid will become creatinine. Okay, so again, creatinine is released to the circulation in a relatively constant rate in proportion to muscle mass. So again, mga bodybuilder, malalaki ang muscles. So men have more creatinine than women kasi 'di ba, more muscle mass ang men. And then it is filtered by the glomerulus into the urine. So, 'di ba? Kasi 113 daltons lang siya. So, what are the clinical applications of creatinine measurement? So, this will determine the sufficiency of kidney function and determine the severity of kidney damage and monitor the progression of kidney disease. So, mostly na mga kakilala nyo, I think, na mga kakilala nyo na may renal failure, they are having serial creatinine measurements. So again, like na if you have relatives na may hypertension, 'di ba? Hypertension can damage your kidneys. So they will be measured, or their creatinine will be measured from time to time to see if there is a decline in the kidney function of the patient. So itong creatinine clearance, that is the amount of creatinine eliminated by the body from by the kidneys from the blood. Okay? So its formula is UV over P times 1.73 over A. So I think you will discuss this in your lab, pero you can look at this so that you will have a guide when you become confused. Okay? So U is urine creatinine, then V is the volume, then P plasma creatinine, and A is the body surface area. Okay? So, skip na natin yan. So, what are the disorders affecting creatinine levels? Okay, what are the disorders affecting creatinine levels? So, when there is, I have a question for you ha. When there is increased plasma creatinine, what does it tell about the patient's renal function? So, increased plasma creatinine. So, is there an impairment of the function or normal function? So there is impairment of the function or there is renal failure. Kasi nga, hindi kayang i-filter ng ating kidney ang creatinine. That's why mag-accumulate siya sa blood. So there will be increased plasma creatinine. So it is actually an insensitive marker and is not measurably increased until the renal function is decreased by 50% or sabi ko kanina 70 to 80%. Okay? So what about muscle diseases? So muscular dystrophy, poliomyelitis, trauma. So how can it affect creatinine? So 'di ba when there are muscle diseases, there will be increase in creatine kasi ma-release niya yung creatine from the muscle. So, kunyari, muscle dystrophy, that will destroy the muscles, di ba? So, when ma-destroy ang muscles mo, it will release the creatine. So, that creatine will become creatinine. So, there will also be increased creatinine. Okay, so when there are muscle diseases, muscle dystrophy, 'di ba polio yung masira ang muscle mo then liliit siya, 'di ba? When you see people with polio. And then trauma, what if mga crush injuries, ganyan. That will increase the creatinine kasi there is increased creatine release from the muscle. Okay, gets nyo guys? Then next, why is there measurement of creatine kinase? 'Di ba ano niya na nakita niyo na yung term na creatine kinase or the CK, 'di ba? So yung CK, 'di ba, that will convert creatine to phosphocreatine or creatine phosphate. Ito yung creatine kinase. So that is also found in the muscle. So when there is muscle disease or when there is trauma to the muscle or destruction of the muscle cells, there will be the release of creatine kinase from the muscle to the blood. So when there is increased creatine kinase, there is muscle destruction. Okay? So again, increased creatinine, increased creatine kinase, increased creatine, muscle destruction. Okay? So we're done with creatinine. So basta remember nyo, urea, protein metabolism, creatinine, muscle metabolism. So let's go to the second to the last, uric acid. So ito very popular itong uric acid, 'di ba? So uric acid is the product of the catabolism of purine nucleic acids. So again, urea, protein, creatinine, muscle, uric acid, nucleic acid. Okay, nasa name niya na din uric acid, purine nucleic acids. So ano yung purine nucleic acids mo? GA, 'di ba? Guanine and adenine. Okay? Guanine and adenine. So, it is relatively insoluble in plasma and in high concentrations can be deposited in the joints and tissue causing pain and inflammation. So, yan yung sinasabi natin na gout, 'di ba? When there is increased uric acid, maganyan ang parents mo na, taasan na sa imong uric acid. Uy, pag diet na dira kay magsakit na po na imong tuhod, ganyan. So that is gout. Yun yung sinasabi nating gout kasi increased uric acid can be deposited in the joints and tissue kaya siya masakit. Okay? So let's talk about its biochemistry. So how is uric acid produced from the purines? So again, purines, guanine and adenine niya siya. Guanine and adenine from the breakdown of ingested nucleic acids. So yung mga kinakain natin na nucleic acids and tissue destruction are converted to uric acid. So 'di ba, asan natin makikita ang purines, 'di ba? RNA and DNA kasi 'di ba RNA and DNA that will become nucleic acids. Then yung nucleic acids that can be catabolize or metabolize into purines. So again, RNA or DNA that will become purines. And then yung purines that will become uric acid. Okay? So purines will become hypoxanthine and guanine and then it will become xanthine, and then itong xanthine, through the use of xanthine oxidase, it will become uric acid. So yung uric acid, that can form crystals in joints. That is what we call gout. Diba? Yung sinabi ko kanina na ma-deposit siya sa joints and sa tissue. And then mostly are excreted in the urine. So 98 to 100% of the filtered uric acid is reabsorbed in the proximal convoluted tubules. So 70% are excreted in the kidneys and others are excreted in the GI tract. Okay, so remember nyo ito na ito na pathway because we will talk about that later again. So, most uric acid in the plasma is in the form of monosodium urate. Kasi, 'di ba sa plasma natin ang pH is neutral to basic, 'di ba? 7 to 7.35 to 7.45. Nasa basic siya na spectrum ng pH. So, kaya siya monosodium urate ang kanyang form kasi nandun siya sa mga basic na pH or neutral na pH. So, dyan sa pH ng plasma, urate is relatively insoluble. So, konti lang ang nadidissolve na urate sa plasma. That is why kapag increase ang iyong urate, increase ang iyong uric acid, those will become deposited sa ating joints, sa ating tissues. That's why maging gouty ang ating patient. So ito, at concentrations greater than 6.8 mg per dl, the plasma is saturated, forming urate crystals. So kapag mas malaki na sa 6.8 mg per dl, so ito lang ang kaya ng ating plasma na i-dissolve. So kapag greater na siya sa 6.8, 7 mg per dl and more, that will form urate crystals. Yun na yung urate crystals, yun na yung ma-deposit sa ating joints, causing pain and inflammation. On the other hand, sa acidic na urine, pH less than 5.75, 'di ba? Sa ating plasma, siya, neutral to basic siya. Ito acidic, less than 5.75. Uric acid predominates and is seen as uric acid crystals. Okay, itong nasa right. Uric acid crystals siya. So hindi siya monosodium urate. Uric acid siya kasi acidic urine. So kapag acidic, uric acid, kapag basic or neutral, monosodium urate. Okay, remember that, guys. So why do we measure for uric acid? So again, diagnosis and monitoring of the treatment of gout, then prevent uric acid nephropathy during chemotherapeutic measurement. So bakit man tayo prevent ng uric acid nephropathy during chemotherapeutic measurement? Kasi 'di ba, where can we get uric acid? From the DNA or RNA siya galing, 'di ba? And then when there is chemotherapeutic treatment, so itong chemotherapy, actually these will destroy the cells in our body kasi gusto niya nga i-destroy ang cancer cells, 'di ba? They want to ang chemotherapy, ang goal niya is to destroy the cells in the body, most likely or parang specifically the cancer cells. So why do we prevent for uric acid nephropathy? Kasi 'di ba, kapag when there is increased destruction of the cells, so ma-release ang RNA and DNA ng cells. At yung RNA at DNA ng cells, it will pass through the this pathway and it will become uric acid. So when there is destruction of cells, there will be increased uric acid. Okay? Next, assess inherited disorders of purine metabolism, and then detect kidney function. So kidney function test din siya. And then assist in the diagnosis of renal calculi. So what are renal calculi? Ito yung stones, renal stones, kidney stones, renal calculi. So how will it assist in the diagnosis of kidney stones? Kasi 'di ba, ma-remember nyo, or if I don't know if you have heard na there are uric acid stones. So there are uric acid stones. So kapag kunyari may stones ang patient, masakit mag-ihi or may blood na sa ihi ng patient, so mag-test ng uric acid kasi baka increase ang uric acid at yun yung nag-form ng stones. Okay? So what are the what are the pathophysiology affecting uric acid productions? So when will there be increased uric acid? So again, gout, 'di ba? Gout. And when there is increased catabolism of nucleic acids, so again, yung chemotherapy, increased destruction of cells, that's why there will be increased uric acid. And then also renal disease, okay? Kasi hindi kayang i-filter ng glomerulus ang uric acid. So gout is found primarily in men 30 to 50 years old. Okay, so mostly men ang may gout. And I think ang kakilala nyo siguro na may gout ay lalaki, di ba? Then this will cause pain and inflammation of the joints. Okay, due to the precipitation of the sodium urate or monosodium urate. Di ba yung sinabi ko kanina? Ito, when you see this, ito yung monosodium urate na nagprecipitate na and deposited in the joints. That's why masakit na siya kasi mag-inflammation na siya dito. Tapos hindi mo na masyadong ma-move ang joint kasi masakit siya. So plasma creatinine is usually, hindi siya creatinine, plasma uric acid is usually greater than 6 milligrams per deciliter. Okay, uric acid yan guys. Plasma uric acid is usually greater than 6 mg per dl, or yung kanina 6.8 mg per dl. Nandyan lang siya na range. Mga 6 to 7 mg per dl, greater than that, will form precipitates of monosodium urate. And again, it can form renal calculi. Kasi diba, when there is increased uric acid, that can form renal stones. Kasi diba, asan na ini-excrete ang ating uric acid? Sa urine. So, kapag dadaan siya doon sa ating urinary system or sa ating excretory system, it can form calculi or stones doon sa ating kidneys. Okay? So, postmenopausal women are prone to gout. So, memorize nilang yan, postmenopausal women are prone to gout. So, itong tophi formation, actually guys, itong mga precipitations of uric acid dito sa ating joints, tissues, those are called tophi or tophus kapag singular. Okay? So, tophi ang tawag niyan. So, tophi are caused by increased uric acid. Okay? So, other causes of increased uric acid, so I have already told you kanina, increased metabolism of cell nuclei, for example, chemotherapy. And the next, hemolytic or megaloblastic anemia. Kasi 'di ba, kapag may hemolytic or megaloblastic anemia, there is increased destruction of red blood cells, causing release of RNA and DNA, causing increased uric acid. The next, renal disease, then pregnancy. So, you already know bakit matataas yan. And then next, Lesch-Nyhan syndrome. So, Lesch-Nyhan syndrome. So, paano siya maka-increase ng uric acid? So, let's go to this pathway again. So, ito, nakikita nyo itong HGPRT. So, di ba from purines, this will be broken down to hypoxanthine and guanine. So, itong hypoxanthine and guanine, this will become salvaged by HGPRT to become purines para gagawin siya ulit na DNA and RNA. So, 'di ba, ang HGPRT, that will decrease the uric acid kasi imbes na pupunta siya dito sa baba to become uric acid, ang hypoxanthine and guanine, that will be salvaged by HGPRT to become purines again. Okay? So, Lesch-Nyhan syndrome is an X-linked, so mostly the boys will be affected. Genetic disorder caused by the complete deficiency of HGPRT or hypoxanthine guanine phosphoribosyltransferase transferase. So kapag may Lesch-Nyhan syndrome ka, wala kang HGPRT. So imbes na masalvage siya to become purines, lahat siya pupunta dito to become uric acid. Okay, gets nyo guys? That's why in Lesch-Nyhan syndrome, there will be increase in uric acid. The next, hypouricemia. So, hypouricemia is decreased in uric acid in the blood, diba? So, what are the causes? Liver disease. Kasi, ito siya, itong production of uric acid, parehas siya sa urea that will happen in the liver. So, when there is liver disease, there is hypouricemia kasi walang production of uric acid. Next, defective tubular reabsorption. Kasi 'di ba, as I have told you earlier, 98 to 100% will be reabsorbed, 'di ba, in the PCT. So kapag when you have Fanconi syndrome, there is defective tubular reabsorption of the uric acid. That's why ma-excrete mo halos lahat ng iyong uric acid, causing hypouricemia or low uric acid in the blood. Kasi hindi siya babalik sa blood, mai-excrete siya kasi hindi niya kayang i-reabsorb. The next, ito, azathioprine or 6-mercaptopurine. So, these are actually inhibitors of purine synthesis. So, kapag konti ang purine, konti lang din ang magiging uric acid. So, memorize nyo lang yan, azathioprine and 6-mercaptopurine. Next, overtreatment with allopurinol. Actually, guys, allopurinol, this is the drug used to lower uric acid. So as you can see, hypoxanthine, xanthine will become uric acid with the use of xanthine oxidase. So kapag when you stop xanthine oxidase, hypoxanthine and xanthine will not become uric acid, causing lower uric acid level, 'di ba? So when there is overtreatment with allopurinol, so sobra-sobra ang yung allopurinol, masyado na ding nasa stop ang xanthine oxidase. So there will be no production of uric acid. You will have hypouricemia. Okay, gets guys? Okay. So ano nyo lang, balikan nyo lang itong causes of increase and decrease uric acid. So let's go to the last NPN, ammonia. So ammonia is produced from the deamination of amino acids during protein metabolism. So 'di ba, as you have learned sa inyong amino acids, ito yung ating structure ng amino acids, 'di ba? May amino group, carboxyl group, side chain group, hydrogen. So itong amino group, ito yung matatanggal sa amino acids. So this NH2 will become ammonia or NH3. Ito yung ammonia. So itong deamination of amino acids, itong NH2, matatanggal siya at yun ang magiging ammonia. So this is converted to urea in the liver kasi 'di ba kanina protein, amino acids will be deaminated to ammonia and ammonia will become urea. Okay? In the liver. So free ammonia is toxic kaya siya ginagawang urea kasi toxic ang ammonia. Ang urea hindi naman siya masyadong toxic, 'di ba? Mas toxic ang ammonia. Okay, that's why it will be become urea. So, why do we test for ammonia measurement? So ito, hepatic failure. Hepatic failure kasi 'di ba? When you have hepatic failure, ang ammonia mo, it cannot become or it cannot be converted to urea. So there will be increase in the ammonia. So when you have hepatic failure, there will be increase in the ammonia and decrease in the urea. Okay, so gets nyo dapat yan guys sa hepatic failure kasi doon siya ginaproduce sa liver. Okay? And then REYE'S syndrome, so let's talk about that later. And then inherited defects in the urea cycle. So ito yung urea cycle, 'di ba? From ammonia to carbon and plus carbon dioxide, it will go through the urea cycle to form urea. So when there is defects dito sa urea cycle, it will not become urea and stay as ammonia. So when you have defects in the urea cycle, you will have increase in ammonia, which is toxic. Okay? So, what is REYE'S syndrome? So, this is a serious and fatal disease and occurs mostly in children. So, kapag REYE'S syndrome, guys, it is preceded by a viral infection. So, 'di ba, when I ask you, kunyari, the 2-year-old child had measles infection and then he was given aspirin. So, you can think of REYE'S syndrome kasi yung viral infection and aspirin that will damage the liver of the child. 'Di ba sa liver doon ginagamit ang doon ginagawa ang urea from ammonia. So when there is a disorder of the liver, the ammonia will stay as ammonia and urea will not be produced. Okay? So kapag REYE'S syndrome, children, viral infection, administration of aspirin, and disorder of the liver. Okay? So, ammonia neurotoxicity. Kasi guys, ang ammonia, 'di ba? I told you kanina, ammonia is toxic. So how can ammonia be toxic to the body? So actually, ang ammonia, it will go to the brain and be added with glutamate. So it will combine with glutamate. So glutamate and ammonia will be uh will be combined into glutamine by glutamine synthase. So glutamate plus ammonia through the use of glutamine synthase will become glutamine. At itong glutamine, guys, it will cause cerebral edema, intracranial hypertension, and neuronal dysfunction causing hepatic encephalopathy. Okay? So yun siya ang kanyang pathophysiology. The ammonia will combine with glutamate by the use of glutamine synthase, and the glutamine, ito talaga yung very toxic sa brain, causing edema, hypertension, and neuronal dysfunction. So kaya siya very toxic ang ating ammonia sa brain. It will cause hepatic encephalopathy. So ang patient mo niyan kay natutulog lang or very confused or na-coma nga in severe cases. So yun siya ang danger ng liver disease, or kaya dyan sa mga mahilig uminom palagi, tapos sira na ang liver, so baka magkakaroon kayo ng hepatic encephalopathy. Okay? So thank you everyone for listening to my lecture. So actually I recorded this lecture at 2 a.m. at medyo lutang na ako, pero I hope you had a lot of learnings, and I hope you get perfect scores in the quizzes and the exams. So thank you, God bless, and always stay healthy.